We are live.
Hello, everyone. Welcome to iFocus Online, and this is the episode 376 and Oculoplasty session 51. And today we have the International MasterClass, and today we have with us Dr. Sara Lally from Wilshire Hospital, and she'll be talking on secondary and metastatic tumors of the orbit. Dr. Lally finished her graduation from the University of Pennsylvania, her med school at Thomas Jefferson Medical College, and went on to do her residency at Geisinger Medical Center at Danville and finished her clinical fellowship in ocular oncology at Wilshire Hospital. And for the past 19 years, she has been pretty much an indispensable part of this practice. And she is very active and in variable professional societies, including the AAO and International Society of Ocular Oncology. She has special interest in conjunctival and eyelid tumors and has worked extensively even on immunotherapy. And she works in collaboration with other departments of Jefferson University and provides best care for the patients with orbital tumors. She's done numerous research projects and for the novel treatments, as I mentioned, the immunotherapy component of conjunctival eyelid and orbital disease. And I must say, in addition, that she's a wonderful mentor, and I'm glad that I am being trained under her. And I learn each and every day. And today we have an opportunity to learn from her on an international platform. So over to you, Dr. Lally.
Thank you. I'm going to start sharing my screen. Good. Can you see my screen?
Yes.
Good. Thank you, Rolika, for your introduction. And as she said, I'm Sara Lally from the Oncology Service here in Philadelphia. It's 9:30 in the morning here, and so I know it's much later in your area, and so I appreciate you being online late night on a Friday night. So on behalf of the oncology service over here at Wills Eye, with Dr. Carol Shields and Dr. Jerry Shields, I'm happy to discuss with you today secondary and metastatic tumors of the orbit. I have no financial interest to discuss. So back in 2002, Jerry and Carol looked at over 1,200 orbital tumors, and they found that metastatic lesions were in 7% and secondary orbital tumors in 11%. These are very complex patients, though, and it takes a good history and physical exam, knowing the treatment modalities, and then later we'll go over some cases and what does the future really hold. So I'm going to go over a few definitions. Primary orbital tumors are those that arise within the bony structure of the orbit. They're like the cavernous hemangioma, lymphangioma, solitary fibrous tumors. I will not be discussing those today, but instead focusing on the secondary orbital tumors. These are ones that extend from adjacent structures around the globe. So from the lids, from the conjunctiva, from the nose, from the sinuses, from the brains. And then also metastatic tumors. They spread through the blood from distant sites to the orbit. And, there's a paucity of data out there about this type of tumors. And so, a lot of it is personal experience and case reports. These types of patients have potentially lethal diagnosis. These diseases kill, and despite interventions, it may not be curative. There's a high rate of recurrence, and it can be very discouraging. So prompt diagnosis and appropriate treatment is needed. Like I said, these are complex patients, and it takes a whole team, a multidisciplinary approach. And so on our service, we have set up an orbital multidisciplinary tumor board where we discuss these patients once a month. And we have the ophthalmology team there, the plastics team, ENT, neurosurge, pathology, med, and rad onc to help come up with the best options for these patients. And I just wanted to show, this is a picture of us all on Zoom discussing our cases every week. So I have learned from the masters, and what have I learned from the masters? Well, you need a good, accurate history. Both Jerry and Carol have instilled when you're here in Philadelphia, getting the history is a key component to coming up with a differential and a diagnosis. Remember the four W's. Who, when, what did they say, and what did they do will help lead you down the right track to make a timely diagnosis and treatment for the patient. Start with a very careful history. When did the duration start? Was it a year ago, 2 years ago, or has it happened over just a few weeks? Ask about different changes in their vision, if they have tearing, double vision, if they've noticed any swelling or droopy lid, pain or numbness can help you also. Many of these tumors, though, will be silent without any orbital signs or symptoms until they get quite advanced. Ask about sinus infections, bloody nose, nasal discharge, and nasal obstruction, because that will help you know, oh, is it starting in an adjacent structure and invading into the orbit? The 7Ps of an orbital history, like we said, the past medical and surgical history. Did they have a history of skin cancer in the past? On the forehead, where was it located? Are they having pain, or is this a painless process? How quickly is it occurring? Is the eye sticking out axially or non-axially? Because that'll tell you, oh, is it coming from behind the eye or from somewhere else? Palpate around the orbit to know, is it hard? Is it soft? Resistance to retropulsion can also help you. And look for changes on the skin. Is there swelling, erythema? Is there ulceration that's there, or lash loss? The second thing that Jerry and Carol also let us know is an accurate physical exam assists you in formulating your differential. So look at the position of the globe. Where is the eye? Is it headed outward? Is it something from the nasal area protruding into the orbit? Is the eye going upward? Is there something in the maxillary sinus pushing the eye? Or even in the lacrimal gland area pushing the globe inferiormedially? Palpate around the eye. Look to see if there's any lumps or bumps, any fullness that's there, the loss of the lid crease. Is it hard? Is it fixed to bone? Is it soft? Look at the motility. Is there restriction in the motility because of the lesion? The other thing is drawing. When we see patients, we examine them carefully and then draw exactly what we see. So when the time of surgery comes, we know exactly what we're going to do and how we're going to approach it best. The imaging will also help you come up with your differential. So using the combination of MRIs and CTs will assist and often are complementary. Many of you already know CT scans help best for bone, can show bony erosions. MRI is best for soft tissue. And I thought this picture kind of really exemplified how you can see the lesion actually splitting the lateral rectus muscle. And tissue diagnosis is the most useful technique to get an accurate diagnosis. Some people are proponents of fine needle aspiration biopsy because it's minimal invasiveness. The problem becomes, is it hard to see? You're kind of blindly sticking a needle in there and you might not get adequate tissue. So when it comes to the oncology department, we prefer complete excision if possible. This way, if that's the only issue they have going on, you've eliminated any other further surgery or treatment that's needed. Most of these patients, though, have unresectable tumors, so you're trying to get a tissue large enough to get sufficient data to make the diagnosis so that you can send it for frozen sections. You can get the pathology, send it for immunohistochemical stains, look at cytogenetics, molecular biologies, or even hormone receptor expression. Speak to your pathologist on how they want the specimen sent. Do they want it sent fresh? Do they want it sent in formaldehyde? And really have a good differential known before going in. So when you send it to pathology, they know what they're looking for and they'll know what stains to send. So now we're going to move on to metastatic lesions of the orbit. In 2000, Jerry and Carol looked at metastatic disease, and they reviewed the literature. The first documented case of orbital metastasis was in 1864 by Horner, and it was lung cancer to the orbit. Since then, over the years, there had been minimal reports of it up until 2000 when Jerry and Carol looked at it. And what they found was breast was most common, followed by lung, then prostate. Interestingly, a significant amount of patients had no known cancer found at the time. So overall, metastasis is very rare, and it occurs less frequently than uveal metastasis. So we see uveal metastasis, every week coming to our office, but really the ones that spread to the orbit are rare. So when they looked at it, the 100 patients, what they found was most commonly was breast, prostate, lung, and skin melanoma. 7%, no primary was ever found. And patients most often had limited motility, followed by proptosis, ptosis, and did have about 40% had a palpable mass. The systemic status 75% actually died from their disease. So as we said before, these patients do have a poor prognosis, and the mean survival is about 20 months at the time of diagnosis in the orbit, with carcinoid tumor having the best prognosis and lung carcinoma having the worst. In the United States, cancer is definitely on the rise. It's projected in 2035 that over 2 million people will be newly diagnosed with cancer. The improved treatment of the systemic disease is increasing the chance for these metastases in these unusual places like the orbit. So these people are being put on better drugs, living healthier lives, and so there's more opportunity for us to see it in the metastasis in the orbit. In addition, there's more advances in the diagnostic testing, so we're knowing what's going on. And the literature has really made it more aware that tumors can spread to the orbit. In actuality, the incidence may be higher than really what's reported because you can have asymptomatic patients, or even once they get widespread mets, they're not going to the doctors, and this may mask any orbital symptoms that they have. A more recent review in 2022 also looked overall at all the literature out there about orbital metastasis. And what they found were that they were most likely happened many years after the initial diagnosis. Most people preferred the biopsy technique, but they found that orbital resection improved clinical outcomes. So again, instead of taking a biopsy of the lesion, it's better to go in and try to remove it completely or decrease the tumor burden. So even if they're needing radiation or other treatments, the tumor burden is not as high. They also found most commonly breast, followed by melanoma, prostate, carcinoid, and then lung cancer as the primary sites. And in this review, the 1-year survival for breast cancer once it spread to the orbit was 57%, followed by carcinoid and melanoma at about 30%. Again, lung cancer to the orbit had the worst prognosis. We're going to move on to secondary tumors of the orbit. And really, there isn't a lot of data that's out there. I only could find one article by Khan Gundes, who looked at over 500 lesions, and what he found was most often they were eyelid tumors, followed by intraocular tumors that spread to the orbit, followed by conjunctival tumors. And again, these tend to be very advanced cases, and over 60% of the patients had exoneration. I think we're going to be seeing more and more of this as the checkpoint inhibitors and immunotherapy get investigated more, seeing how these tumors respond. So again, secondary tumors are tumors that are in tissue around the globe that are extending into the orbit. In both cases, how do we treat them, though? There are multiple treatment modalities: radiotherapy, chemotherapy, hormone therapy, surgery, and immunotherapy. Immunotherapy is definitely a hot topic, and I'll get into that a little bit later. So radiotherapy, there's a balance between the tumor responsiveness and the toxicity to the vital structures. The dose of radiation depends on the diagnosis, and it's really important to forewarn these patients about the radiation side effects: the retinopathy, the vision loss, the glaucoma, the scarring, the dry eye. You know, these patients have already been through a lot, and then their eye becomes painful afterwards from the radiation. More recently, stereotactic radiation can help minimize these side effects. But again, because it's so precise, if your field isn't drawn exactly around your tumor, there's a chance that you're not treating your tumor completely. So in our hands, we'll work with our radiation oncologists. We'll go over there to their department. And because we've already been in the orbit, making the diagnosis, doing the biopsy, we will actually outline where the tumor is to make sure that all areas are included. And here is just one of the imaging scans showing for CyberKnife. Chemotherapy is the gold standard for treatment of metastatic cancers. They can provide a prolonged remission, but usually are palliative. And now, more recently, are used in combination with immunotherapy or radiation. Hormonal therapy is used with breast cancer or prostate cancer. And so these patients will be able to decrease the survival of the cancer cells by having a low hormonal environment. And like we talked about earlier, surgery gives you the tissue conformation. It can be a cure for advanced disease. You can also decrease their symptoms. So even though you can't remove it completely, if you take out as much as you can, maybe the double vision will be improved, or the compression on the optic nerve causing, or the globe causing a decreased vision. And as we saw in previous studies, it may also help with survival. Now, these are very advanced cases, and you can see here he has a medium forehead lesion extending into the orbit. What do you do when you have surgery and it's so advanced like this? Orbital exoneration can be done, but then you need to close the defect. So we'll work with our otolaryngology department, who will put up free flaps when it's a large defect. So when we're having to take out bone, in addition to the orbital contents, they like to use the thigh. The nice thing about when they take skin from the thigh, they can close it primarily, and the patient doesn't need a second procedure. And that patient that I just showed you has the thigh free flap. Most of these patients are getting radiation afterwards. So you can see in the right-hand picture, he still has a lot of hair on that graft, and it is quite bulky. The radiation will eliminate that. And eventually he will get a debulking procedure so that he'll be able to wear a prosthesis. This patient has fullness of that lower lid with lash loss. When we look at imaging studies, again, we see mostly inferiorly the lesion. So when we go to do exoneration here, we can save the upper lid and take all of the lower lid down onto the cheek. When you're able to save a tissue around the eye, like the upper lid, then you don't need as much tissue for closure, and we're not taking out bone. So our ENT department will go to the arm and do a radial forearm flap. This is nice, thin tissue that actually maintains the concavity of the orbit. However, the one downfall is they need a second procedure to close the skin completely. And this patient had from her radial forearm, and you can see that concavity of the orbits that's there. Patients will get prostheses. This gentleman had a basal cell medially, needed exoneration. Bone had to be removed also. He has a thigh free flap up there, superior uh, uh, on the right-hand side of the photo. He's well healed on the left lower photo, and then with his prosthesis in, you can see he looks quite good. There is debate if even orbital exoneration improves survival in cancers. You know, the new thought is that, and I just put up the one article by Paradins about conjunctival melanoma. It did not improve survival. And so, you know, if we're not improving survival and we're doing radical surgery, you know, is it really worth it? Because we are kind of impacting these patients, and is there really other options for them? And really using that multidisciplinary approach with having the multiple teams kind of talking. We're getting input from what the ENT guys do with squamous cell in the mouth. Does it apply to the conjunctiva? And trying to come up with the best options for these patients. Which brings us to the latest and hottest thing out there, immunotherapy. So what is immunotherapy? Well, it's the prevention of or treatment of disease by stimulating or suppressing the immune system. Vaccines, toxins, cytokines, monoclonal antibodies are all immunotherapy, and checkpoint inhibitors. So back in the 1800s, Coley, he looked at injecting strep virus into patients with osteosarcoma, and he cured some of them. He was really the first person, is considered the grandfather of immunotherapy. He was kind of poo-pooed, though, for a long time because Ewing radiation was a dominant force at that time, and he recommended radiation. So immunotherapy kind of got put on the back burner for many years. As time went on, though, we learned more and more about the immune system. Studies were looking at how we can change the immune system to get rid of cancers. And really, the game changer came in the 1990s with this discovery of these checkpoint inhibitors. James Allison was the first to show the T cell inhibitory molecule called CTLA4 could enhance anti-tumor immune response and tumor rejection. And in 2018, he won the Nobel Prize for his discovery. And then really in 2011, the first checkpoint inhibitor was approved. So what are checkpoint inhibitors? Well, they're drugs that block proteins that stop the immune system from attacking cancer cells. So we're going to go back to immunology, back to medical school, and 101, kind of the basics here. So in your immune system, you have T cells. On these T cells, there are proteins that are these checkpoints that help turn on or off your immune system. For example, if you get a virus, the antigen presenting cell goes to the T cell, it activates it. The T cell will make cytokines, which then attack the affected cell and cause the cell to die that has the virus in it. When it comes to cancer, cancer can hide from your immune system because of these different proteins and can block the T cell from recognizing that the cancer cell is there, and it allows the cancer cell to proliferate. So it kind of blinds the T cells to the cancer cells. But the checkpoint inhibitors block that ability of the cancer cell to do that so that the cancer cells can be attacked by the immune system. So there's different drugs that block different checkpoints. So like we talked about before, there's the first one that was discovered, which was the CTLA4, and then also PD-1 and PDL1. The use of checkpoint inhibitors is on the rise. So back when it was first discovered or FDA approved back in 2011, about 2% of cancers were used, and it was mostly used in melanoma. But as time has gone on, these are used more and more often. And I'll tell you, on our tumor board, when we have cases where we don't know what to do, it seems like the medical oncologists are willing to throw checkpoint inhibitors at these patients to see if there's a response or not. So really, there needs to be a lot longer follow-up and to see how patients respond to these different drugs. So when we look, this is kind of more of a schematic looking. You'll see the PDL1 and the PD1 are both, or sorry, PDL1 are on the cancer cells, where PD1 and CTLA are on the T cell. So they'll use different drugs in combination to try to deactivate the cancer cells. And listed here are also some of the immunotherapy drugs that are out there. The most common ones that you've probably heard of are Ipi, Nivo, Pembro. More recently, cemiplimab has been used with squamous cells and basal cells. And in the United States, of those that are approved, most often it is for melanoma, followed by squamous cell. We will see these also used in Merkel cell carcinoma. I'm not going to talk about Merkel cell today. So these drugs boost the immune cells to fight the cancers, but they also can have many side effects. They systemically can cause tiredness, most commonly. They can cause nausea, skin rash, diarrhea, shortness of breath. And from the eye standpoint, the immune system gets unleashed. Lauren Dalvin and Carol Shields kind of looked at these side effects on the eye itself. And what they found was, like I said, it affects the entire body and it unleashes the immune system. And when it comes to the eye, you can get pink eye, you can get inflammation inside the eye, you can get anterior chamber reaction, vitritis, optic neuropathy from it. So it really affects the eyes and the entire body. And I think more and more as these drugs are getting used, that we will see the side effects of these medications. The other thing that we're seeing now too, patients are getting put on these drugs, and the globe is a privy area that a lot of these medications don't always cross. So that, their skin melanoma is treated, the widespread METS is treated, but we're seeing involvement still in the vitreous. So now I'm going to move on to just a few cases to kind of complement what we've been discussing about here. So this patient was a 33-year-old woman who had a pigmented lesion that was biopsied elsewhere and was sent to us for evaluation. The initial biopsy showed conjunctival melanoma followed with arising from primary acquired melanosis. We re-excised the wound because the initial specimen showed melanoma, and our biopsy showed primary acquired melanosis with atypia. She did have multiple recurrences of the primary acquired melanosis and melanoma over time. But in 2014, she was looking pretty good. That temporal scar looked excellent, and there was no signs of recurrence. Well, a year later, she sends us a photo of her and she says, "Oh, I can't lift my lid." Orbital imaging was done, which showed massive involvement into the orbit, almost back to the apex. And she underwent orbital exoneration, and a year later, at age 42, died of melanoma. She was before really the checkpoint inhibitors have been being used for conjunctival melanoma. It's most often used for skin melanoma. It's hard because these drugs are expensive to get them paid within the United States. But more and more patients are being put on these checkpoint inhibitors to try to keep things at bay. So what is conjunctival melanoma? It happens in about 5.5 in a million in the white population. The etiology is not known. It's seen in lighter complected and sunlight exposure areas. We don't know what causes conjunctival melanoma, and there's a need to find the genetic testing. So we looked at over 100 patients with specimens, and what we found was there were certain mutations that happened with high frequency, which included NF1, BRAF, which is also seen in skin melanoma, NRAS seen in skin melanoma, and ATRX. There were a host of other mutations that were seen also. So it's not just one mutation that causes conjunctival melanoma. And we don't really know what causes some conjunctival melanoma to be more aggressive than others. And so the goal is by using biomarkers to look at mutations and immunotherapy, can we predict who's going to become like that patient I just showed you and need rapid, quick treatment for prevention. So in cutaneous melanoma, conjunctival melanoma is a distinct disease. Those mutations are not the same. And we do see sunlight mutations in our patients, but not necessarily in sunlit areas. Unlike uveal melanoma, which has certain mutations, conjunctival melanoma does not have those same mutations. Although we did see it in over 100 patients, only 4 patients. And what we found were these patients had more advanced disease, likely involvement of the lacrimal drainage system, and a high propensity for liver metastasis and death. The NF1 mutation was found to be a lower rate of metastasis at 2 and 5 years. This was a newer mutation, so really the long-term results are still pending. BRAF, in the skin world, BRAF mutation was considered a very aggressive, deadly disease, and that's why they made drugs that work towards the BRAF mutation. When it comes to conjunctival melanoma, this was not associated with increased risk of death and Mets. NRAS, though, like skin melanoma, is at a higher rate for Mets and death. And these patients we're trying to put on checkpoint inhibitors to see if we can decrease the chance of both of those outcomes. ATRX, like NF1, showed a lower rate of metastasis at 2 and 5 years. And again, this was found more recent mutations, so the long-term data is still pending. So you can think of conjunctival melanoma as distinct groups. Some of them behave like the cutaneous melanomas with the BRAF and the NRAS mutation. Others like CNS neural crest tumors with the NF1 and ATRX mutations. Others like uveal melanoma, very aggressive. And then there's a fifth group, a wild type, where we can't find the mutation. The patient that I presented, no mutation was ever found in her. So I wonder if there's a mutation that's out there we just don't know about yet that causes these very aggressive diseases and extension into the orbit. The next case I'm going to discuss is a woman who noted puffiness of her right upper lid. She had good vision. As you can see, there's 2 millimeters of approximately of upper lid ptosis. She did have decreased motility on upgaze. No proptosis was noted, and her color plates were full. Now, in the back of my head, I'm hearing Jerry and Carol tell me, well, what else is there to know about her? Well, she did have a history of, sorry, I have it spelled wrong, stage 4 breast cancer with mets to the bone and the liver. And so she was on hormone therapy and chemotherapy. When you look at her MRI scan, you can definitely see the enhancement on the right side. The fat behind the left globe looks a little streaky also. And so she was felt to have metastasis to both orbits. We did a biopsy on the right side, which confirmed the diagnosis of invasive breast carcinoma. And since it was bilateral disease, radiation was recommended to both eyes since she had already been put on chemotherapy and hormone therapy. She died 3 years later. And again, just like we've seen in the data that's out there, she had a longer survival, but once you get Mets to the orbit, you're generally thinking about a 2-year life expectancy when it comes to breast cancer. So breast cancer is the most common cause of cancer-related death in the Western world. When you look at people who have breast cancer, about 29 to 50% will have orbital Mets. It can occur years later, even decades later after successful initial treatment. I can't tell you how many women we've had who have come here. They had breast cancer 20 years ago. Everything's been stable, nothing going on. Their medical oncologist kind of signs off on them and they start to get symptoms around the eye. And you're like, oh, it's probably breast cancer. And they sit there and argue with you, no, I don't have breast cancer there. Most commonly, double vision or decreased motility is seen. And in breast cancer, when you have the sclerosing form, it can induce anophthalmos. So it can actually make you look like the other eye is proptotic because the eye is kind of sunken in. About 15% of cases will have bilateral involvement. So patients are treated with chemotherapy and hormone therapy depending on their receptors. Radiation with stereotactic minimizes the effect to the eye. And despite the combination of all these therapies, most often therapy is palliative in these cases. The next case I'm going to present is a woman who noted double vision and decreased vision on the left side. She had, and you can kind of see that loss of the lid crease down below on the left side with 2 millimeters of proptosis. She had 8 out of 8 color plates on the right and 0 out of 8 on the left. So when we start to see that, we're worried about, optic nerve involvement. In addition, she could not move the eye to the left. So again, in the back of my head, let's think about what's going on in this history. And let's do a really good physical exam. And it's quite subtle and the picture is a little blurry. But when you look up above on the forehead here, you can see a scar. Well, she had a history of skin melanoma back in 2008. It recurred in 2011. And then just 2 weeks prior to visiting us, she was found to have widespread metastatic melanoma to multiple organs. So this is the case that I showed earlier of the MRI with the beautiful tumor that you can see in the lateral rectus muscle extending back to the apex. On coronal, you can't even see the nerve to know, but obviously there's compression with the decreased vision and the 0 out of 8 color plates. So what do we do for her? This woman has widespread metastasis. She's extremely bothered by the decreased vision. So we went in and removed the tumor. We did a lateral canthotomy, removed that lateral rectus muscle, and you can kind of see the suture that's up above. Way back by the orbit, there's still a residual that's there. We were unable to get it out completely, and it was so necrotic, it just comes out in tiny pieces and close her back up. So she had radiation to the orbit. She was put on Pembro for 1.5 years for her systemic involvement. And she is one of those miracles. 8 years later, she is disease-free with no signs of recurrence around the eye or around the orbit. She did have the radiation to that side, and you can kind of see that sunken globe that's there. And she does have dry eye and radiation retinopathy for which she gets injections. So looking at advanced melanoma, we talked about Keytruda. This was one of the first immunotherapies that are out there. There were a bunch of different studies that showed that Pembro alone resulted in a 30 to 40% clinical complete response, right? But that means that 60 to 70% of people aren't responding at all. So it's not the end all be all, but it actually gives much better survival compared to other options. So really, this drug and other drugs like it, when it comes to melanoma, it definitely game changers. The next case I'm going to present is of a 65-year-old woman who droopy lid on the right side for about 2 months. And actually, all right, we're doing our physical exam here. We're starting to see that lid looks a little droopy up above. Her tell showed about 4 millimeters of proptosis, but you can see that scleral show inferiorly, telling us that something is pushing the eye up. She had resistance to retropulsion and a palpable nodule around the inferior rim. So we're using our kind of history, our physical exam to kind of figure out what's going on. And when we probe more into her history, well, she has a history of bilateral breast cancer and carcinoid. So, two different types of cancers. She's bothered by her droopy lid and, trying to figure out, does she have metastatic disease from the breast cancer or from the carcinoid? What's going on? She went for orbitotomy. You can kind of see it's kind of hard to know, but there is enhancement inferiorly in the orbit on that right side on MRI scan. And went in and dissected this tumor off the oblique muscle, which proved to be carcinoid, not breast cancer. And because carcinoid is more low grade, it was removed completely at that time. Nothing further was needed to be done to the orbit. She was treated for her systemic disease with lanreotide. So, there's not much in the literature about carcinoid to the Mets. Shields et al. Reviewed 4 cases. They found that the interval between diagnosis and the orbit involved is usually around 8 years. One pearl I want to give you is that carcinoid of the intestines goes to the orbit, carcinoid of the lung goes to the uvea. So those are two kind of distinct pathways by which they spread. Further study review article showed that the management of carcinoid is controversial. They didn't feel that surgery really provided any longer survival. Most of the time it's done for diagnosis and also if patients are symptomatic with double vision to try to relieve that. They found no difference between observation versus radiation versus octreotide treatment. So next, I'm going to kind of move quickly here. We had a woman who had a conjunctival lesion on the left eye. She has a history of transplant and is immunosuppressed. The right eye shows some blepharon and some keratinization in the caruncle. Left eye showed a squamous lesion that was there, and she was treated with interferon. The lesion persisted, and she was started on 5-FU for actually, she looked pretty good, and maybe just a little bit of leukoplakia that was there, and cryotherapy was performed. 10 months later, she came back with this massive tumor. She underwent excision and reconstruction. Pathology confirmed conjunctival squamous cell into the orbit. In addition, she did have perineural invasion. So this ends up being, even though you have all final surgical margins negative, this perineural invasion ends up being an issue, and what to do about it, especially in the immune compromised population. She came back to see us on follow-up and was noted to have a lesion in the orbit and underwent exoneration, for which all final margins were negative also. She received radiation to the orbit and the neck, and then had recurrence in 2022. We last saw her last week, and she was stable without recurrence. So really, these immunosuppressed patients, you got to watch out for with these squamous cells. These are aggressive and bad diseases. And, treating with topical drops, injections isn't going to make much difference. They need surgery. The hope is that eventually these patients can be put on checkpoint inhibitors, but you think you're suppressing their immune system and then you're trying to activate their immune system can really be a problem. And so, checkpoint inhibitors can't be used in them right now, but a study was done more recently that showed that there was effectiveness and safety to the PD-1 inhibitors in those immune suppressed patients. So hopefully that will be in the pipeline. And then finally, I'm going to talk about a patient that had a lesion in the medial canthal area here. It was seen mostly anterior orbit, extending from the conjunctiva onto the skin and into the orbit. Biopsy showed a squamous cell carcinoma, HPV negative, and it had low tumor mutational burden. We referred her to medical oncology because of the aggressiveness of the disease, and she was started on cemiplimab. She underwent one cycle. She felt like her eye was getting better. She came back to see us, and we actually thought it did look better than when we first met her. The photo on the right side is a date first seen. Underwent a few more treatments, a total of 4, and then came back to see us, and more aggressive with more scatter onto the lid, and she was more concerned that her vision was getting blurry. Took her for excision, and pathology revealed a partial response of the tumor with only 20% of the viable tumor in the tissue. All margins were negative in her. This is her on follow-up 3 weeks later. So cemiplimab binds to PD-1 on T cells and blocks the PD-1 pathway. It is now used for non-small cell lung cancer, squamous cell, and basal cell. We really don't know how this drug is going to affect in the long run. There have been multiple studies kind of looking at cemiplimab. And some people feel that those patients that had high tumor mutational burden respond better. Our patient had a low mutational burden. Really, we don't know what the HPV status means like we do in the other head and neck squamous cells. And it's an exciting time from this standpoint to see how these patients and trying to figure out who's going to respond, who's not going to respond to give them the best prognosis. So in summary, secondary tumors arise from structures around the orbit. Mets spread via blood to the orbit. These are very complex patients and need a multidisciplinary approach. Sometimes, despite all the treatments, prognosis can be poor. Immunotherapy is a game changer, and more investigations are needed for biomarkers and the targeted therapies. So on behalf of the oncology service at Wills Eye, I want to thank you for your time.
Thank you so much, Dr. Lally. And I agree with you. You have kind of simplified the entire topic. I know that the topic of orbital metastasis is rare, but the way you showed the cases, it became it very easy for everybody to understand the importance of a multidisciplinary approach, thorough imaging, and even the importance of immunotherapy. And we love the animation, how you've put it together. It was, I think, very easy for everybody to understand that of how checkpoint inhibitors really work, because it's rare, it's new, and at the same time, it's pretty complicated for people to understand how it goes. And a very interesting table where you've enlisted all the drugs that are being currently used. I landed up taking a screenshot too. So thank you so much for that. We have a few questions for you. So the first question would be that you mentioned about the occurrence of tumors as secondaries in the orbit, right? What is the standard duration, the mean duration, the gap that you see between their primary and the secondary occurring in the orbit?
So I think it depends on their immune status and how advanced and actually what type of cancer it is. Like the basal cells can be there for years before they really start to cause a problem, invade into the orbit. The squamous cells are kind of the same. If you get adenosquamous cell, those ones tend to be a little more aggressive and grow faster. And so it just depends. But I would say, the orbit is one of those areas where there's a lot of tissue around it. And so they can get quite large and be there for a long time before people really become symptomatic about it. So, they may think, oh, I just have like a little ulceration on my lower lid or my lashes are thin there, but not really realize what's going on. And it can go on for a really long time.
Right. And you did mention that, like, for example, in breast carcinoma, the lifetime risk is 12.3%, which is quite a high number for these patients. So would you suggest the oncologists to have like regular MRI orbit scans, or do you think that it's a good idea to do that?
So I think if they get so I think the oncologists like the PET scans to look for activity. The thing with a PET scan is lots of times when they order it, it goes from the neck to the thigh, right? It doesn't include the head. And so I think it is worthwhile, especially in those that are more common that have known metastatic disease. I don't know if I'd start from the beginning when you're diagnosed with the breast cancer, but once metastasis is seen, including the head, to make sure that the orbit isn't involved.
Right. Thank you for that. And one more thing is that you had mentioned about the grafts, like how beautifully the thigh graft was done in the patient with the exenteration. And how often do you see radiation-induced necrosis in the patients who have been grafted after exenteration?
So they usually have those free flaps because they put the vasculature together. They let it heal for a period of time. So it happens, but they'll wait for the radiation to be done to make sure that it's a well vascularized flap before they do anything from the radiation standpoint. I think it's more in those patients that have had radiation prior to getting the exoneration where the tissue isn't as healthy. And so the graft has a harder time taking. And so in those patients, it may not heal as well. Um, but when we do our surgery, we try to include that tissue because you can kind of see the skin changes from the radiation in our specimen, just to eliminate that chance.
Right. And in conjunction to this question, what duration would you prefer to keep between the graft and the radiation? Like, what is your recommendation?
Yeah, I think they'll do a couple months before they will uh like 2 months before they'll do the radiation, six weeks or so.
Okay, right. Another question would be that in these cases where there is diffuse lesion, you mentioned that it's best to do debulking. So, what would be your comment on the cases which are like extensively diffuse, where even when you debulk and there is residual disease left out, would you advise them to go ahead with systemic chemotherapy or immunotherapy in these patients?
Yeah, so we would definitely present it to our tumor board and based on diagnosis to go on systemic therapy. It seems like perineural invasion. There's been recent talk about putting people on immunotherapy instead of doing radiation for squamous cell. So I think that it definitely, comes into play with those diseases. And it looks like Carol's on too.
Yeah, no, I would just like to ask if anyone else had questions for you. I thought that was a really nice overview. It's not easy to manage orbital tumors.
No.
Right. I believe
Any
Ruju
other
also has
doctors
one
have
question.
anyone else have any questions like Dr. Ruju or Dr. Farnaz? No? Dr. Athar?
Dr. Ruju, you have few questions, right? You can go ahead and ask those.
I just had one question that does histopathological evaluation guide to a probable site of primary malignancy, like probably a case of sweat gland carcinoma of a palate can guide us to probable breast carcinoma? Is there any other example, or is there any particular malignancy in which histopathology could probably guide us towards a primary site of malignancy?
So definitely they'll use those immunohistorical stains to try to figure out what the primary is, especially if there isn't any known diagnosis at that time. So that's why I had said, it's important to talk to your pathologist and come up with the best differential that you have, so that they know what kind of special stains to order. And then they're pretty good with when they look and see, oh, if there is something that kind of is highlighted, they'll send it for those studies. Good.
Right. Farnaz, would you like to ask something else too?
Among like these patients, like what would be your comment on tumor-induced necrosis?
So we do see that. And actually, that last case that I presented, you know, they thought the medical oncologist thought it was getting worse in the beginning because they get this tumor necrosis and you can get more swelling and the tumor can look bigger before it shrinks down. So I think when it comes to immunotherapy now, they'll give a total of like 4 doses before they make that decision. But definitely you can see like enlargement of tumors or things looking worse before they get better.
Thank you.
Right. Ashwita, would you like to ask something too?
Hi, ma'am. Thank you so much for that presentation. That was really a topic which was very new to us, and you covered it very well. I do have a question. I would want to know, how do we assess pseudoproptosis in these patients, and how do we go about, looking for this, and how do we measure it, ma'am?
Yep. So we'll use the Hertels, right, to see if one eye greater than 2 millimeters difference between the two will tell you if there's proptosis. Now, granted, based on different races, there's difference in the Hertels from that standpoint. But really, what ends up being is getting a really good history. Like I said, looking for histories of cancers to know. Is this, on the right side or the left side? Looking at the physical exam, palpating, looking at motility, is there decreased motility? So, like in breast cancer, when it's more sunken socket, the good eye can look like the proptotic eye. And so, really, you want to look at the motility, palpate around there, because lots of times you'll feel some thickening at that orbital rim from the breast cancer. But really, Hertels will help you from that standpoint. And then also how your globe is displaced inframedially or superiorly, kind of helping you guide where things are located.
Thank you, ma'am.
Right. And we have one last question for you, Dr. Ali, before we conclude this session. And the question is that in extremely posterior lesions, that are those inoperable lesions where it's difficult to access, like towards the corneal area, what would you recommend? Would you recommend like stereotactic radiation in those patients?
Yeah, so you need a tissue diagnosis to know exactly what you're dealing with. So lots of times, we'll defer with ENT or neurosurge if they're going to do the biopsy because they can get back there, especially endoscopically. And then based on exactly what the tumor is, checkpoint inhibitors or even radiation can be done. Most of the time they will kind of bombard that area because that's like a main path to the brain. And they don't want to get the cat out of the bag.
Right.
Okay.
Yeah. Thank you so much, Dr. Lally, for the wonderful session. It was an extremely interesting and knowledgeable section for all of us. And we've learned a lot about orbital tumors. And I think that even the general ophthalmologist viewing this, or even the residents and the fellows who are viewing this session, everybody had a lot to gain from this. And we thank you so much for your precious time on this early morning. We know that you have a very busy day, so we won't hold you up. Thank you so much.
Thank you.
Thank you.
Bye-bye.
Have a great day. Sunilji, are we offline? Oh, it's in my hands, is it?
Not yet, ma'am. Before we call it a day, I would like to make a small announcement. Next, we meet on Feb 7th, and Dr. Rose will be talking to us on techniques in orbitotomy. See you all on next Wednesday, Feb 7th. Thank you. Good night, everyone.
Thank you.